On this episode of the ASC Podcast with John Goehle, we prepare for our visit to Dallas this week for the ASC Nurse Leadership Conference, talk about a recent issue about day-use tubing, celebrate the Year of the Nurse, discuss Tricare's proposed movement to the Medicare Payment System, and in our focus segment, discuss communication in your quality improvement program and interview Ann Shimek about developing a culture of quality in your ASC.
Welcome to the ASC Podcast with John Goehle, a podcast for anyone interested in the freestanding ambulatory surgery industry. This episode is sponsored by Ambulatory Healthcare Strategies. The ASC regulatory environment is increasingly challenging, but organizations that outsource their regulatory oversight to ambulatory healthcare strategies have an edge. AHS works with ASCs to oversee their quality improvement, risk management, emergency and infection control programs, run their meetings, develop education programs, and always be prepared for surveys.
Welcome to episode 85 of the ASC Podcast with John Goehle for February 3rd, 2020, recording from our studio in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast and Senior Nurse Consultant for Ambulatory Healthcare Strategies, and I'm here with John Goehle, recognized as one of the nation's leading experts in the ambulatory surgery industry. John is the author of a number of books about the industry and the owner of Ambulatory Healthcare Strategies, the industry leader in ASC regulatory and accreditation, governance, and quality improvement oversight.
So how do you like your new screen?
It's so cute. You put a picture of a little golden retriever puppy, the little light-colored ones, like what we're waiting for.
No, we're waiting for the
adorable.
News. Our puppy should be born any time now. We're still waiting for the news on it. So I thought I'd surprise her with pictures on her brand new computer screens here. So thanks to the generous support of all of our listeners and our sponsors, we have been upgrading the equipment in our studio here. And now we have all new iMac machines for recording and for monitoring all the activities going on in the studio. So, but the background are all puppies. So we have a busy week this week. We're on the road to the ASC Nurse Leadership Conference on Thursday, February 6th.
Yep, we're going to Dallas.
We're going to Dallas. Sue and I are flying down on Wednesday evening, and we'll be there for the whole conference. Ambulatory Healthcare Strategies is a sponsor. We'll have a booth there, and we hope to record some interviews, and maybe we'll have a special episode, depending upon our timing. And then next week, we have a very exciting episode coming up. SIS joins us as a sponsor next week, and to kick it off, we're going to have an interview with Craig Veach, which is going to be a look back in the last 50 years in the ASC industry. So, for those who don't know, Craig Veach is retired from Surgical Information Systems, but he does still do some work for them. He started in the industry about the same time as I did, actually, so I was looking at it. He actually started 3 years after I started, and he's retired and I'm not. But this should be a real fun look back to see how the industry has changed over the past 50 years, and even in the 30 years that both Craig and I have been in it. So stay tuned for that episode next week.
Yeah, I'm looking forward to that one.
So just to put this in perspective, this week, one of our clients had an issue with regard to day-use tubing. And the vendor had brought this product in and asked the employees to start using it. The problem was, while there's really no problem when using day-use tubing, as long as it has the backflow preventer in it, the nurse manager and the medical director did not know about this. It hadn't been brought in front of the Quality Improvement Committee, and basically the vendor just brought it in and they started using it. As soon as the nurse manager and the medical director found out what was going on, they immediately stopped it. And then after some conversations with the nursing team, it was decided that that wasn't something that they wanted to be doing. Again, I don't really want to talk about the day-use tubing and its efficacy. Really, the issue here is the importance of making sure you have good communication in your organization and that you just don't let a vendor come in and kind of do their own thing. Anything that is brought into the facility, any new equipment, any new supplies, they really have to be, at the very least, brought in front of the nursing director, and especially in this case, the infection control coordinator, which in this particular facility is the same person.
And they would have had to retrain the staff as well. If they had
That's
decided to use this, you just can't go ahead and replace it. They would have had to plan out, did they need new competencies?
Right.
Did they have to change their policy?
Yeah.
There's so much involved in it. So.
And remember, the rules are also that your vendors do not teach your staff. Your vendors kind of teach a person who then will teach the staff. You never want a vendor to be providing the sole education on new equipment, new supplies, et cetera, in your organization. That has to be kind of a train the trainer type situation where that, they can do it at the same time. They can be training, the staff at the same time as the person who'll be doing all the ongoing training. But it's extremely important that you understand that those vendors are not going to be there all the time. So there has to be expertise in your organization as to how to use these supplies and equipment. And that is a standard. That's an accreditation standard. So again, it was kind of an unfortunate situation. It was rectified quite quickly as soon as the nurse manager and the medical director found out about it. And kudos for the nursing staff to quickly bring it to their attention when it was quite apparent that they had not been involved in the decision process.
And moving on to the news, the World Health Organization has designated 2020 as the year of the nurse and midwife to honor Florence Nightingale's 200th birthday, who was highlighting the need to invest in strengthening the nursing and midwifery workforce. In many areas, there aren't enough nurses and midwives. Even when they are present, they may lack the power, training, equipment, and medical supplies to deliver basic health services.
Does this mean I have to bow down to you every time I see you?
Yes.
Okay.
For at least all of 2020. And we can carry it on as long as...
Well, it's about time you get recognized for the wonderful work that all of you nurses do.
I agree. And just some statistics that were in their International Year of the Nurse and Midwife Toolkit that they have on the World Health Organization's website, if you're interested in going to it. They mentioned that there's 22 million nurses and 2 million midwives worldwide, which makes up half of the global health workforce. They estimate that the world will need 18 million more health workers to achieve and sustain universal health coverage by 2030. And approximately half of that shortfall, or 9 million health workers, are nurses and midwives. Midwifery work here includes proven interventions for maternal and newborn health as well as for family planning, could avert over 80% of all maternal deaths, stillbirths, and neonatal deaths. Midwife-led continuity of care, where a known midwife or group of midwives provides care for pregnancy to the end of the postnatal period, can prevent 24% of preterm births. So I know that's not really in our industry, but I just think it's really important. They're going to have things going on throughout the year, just hoping to build the nursing workforce.
And just a point of clarification here, Sue is a pediatric nurse by training, so that's why this is a little bit focused on that area.
Yes.
But I think the whole point here is recognize the importance of nursing and how it is such an important part of what we do in our industry, and trying to encourage your children and grandchildren to pursue a career in the healthcare field, and if they so wish, in the nursing in particular. So hopefully this will bring a lot more attention to the workforce issues that we're going to be facing over the next couple decades.
Yeah, we already know in the ASC industry that it's always hard to get great nurses.
That's right. I did want to talk a little bit about Tricare. So in a proposed rule by the Defense Department published in the Federal Register on November 29th of last year, entitled Tricare, Reimbursement of Ambulatory Surgery Centers and Outpatient Services Provided in Cancer and Children's Hospitals, Tricare proposed moving to the Medicare Reimbursement System for Tricare patients. So in the Federal Register release, they stated the following. The Department of Defense Health Agency is proposing to amend its reimbursement of ambulatory surgery centers, ASCs, and outpatient services provided in cancer and children's hospitals, better known as CCHs. The proposed revisions are in accordance with the Tricare statute that requires Tricare's payment methods for institutional care to be determined to the extent practical in accordance with the same reimbursement rules as apply to payments to providers of services of the same type under Medicare. In accordance with this requirement, Tricare proposes to adopt the Medicare payment methodology for ASCs and to adopt Medicare's payment methodology for outpatient services provided in CCHs. So the important takeaway here is that right now Tricare is reimbursed quite well in many settings, and they are proposing moving to the Medicare reimbursement mechanism. And the ASC Association responded to the proposal in late January, stating the following. Although Medicare is an established payment system, it is also the lowest common denominator regarding payment for outpatient surgical procedures. While impact on specific procedure reimbursement may vary, ASCA has heard from our members that some procedures will receive significantly lower reimbursement under the proposed alignment so as to make them unviable to offer to Tricare beneficiaries. This loss of access is not ideal, but possibly unavoidable as ASCs often operate as small businesses with narrow margins. Although Tricare seems to be saving money on lower reimbursement per procedure, the result may be, in fact, higher spending if ASCs do not perform procedures and they are instead performed in the much higher cost HOPD setting. This effect will likely be exacerbated by the lack of a transition period for ASCs to acclimate to the new alignment. Tricare notes that some providers may see increased reimbursement after this change, and a transition period would make such providers wait to realize higher reimbursement. ASCA urges the Department of Defense to reconsider their proposal to adopt the Medicare ASC list in its entirety with no deviations or exceptions so as to prevent loss of access to certain services for Tricare beneficiaries. So hopefully the Department of Defense will take these comments under consideration, because I think our big concern here is that if it is no longer financially viable for ambulatory surgery centers to do the procedures under the Medicare reimbursement system for Tricare patients, those procedures, as ASCA indicated, would move back to a much more expensive hospital setting, which I'm sure they didn't take into consideration when they tried to determine what the fiscal impact would be of this. So thank you to the ASC Association again for protecting our interests, and we will keep you informed as we hear more about the future reimbursement under Tricare. So let's take a short break, and we'll come back and have our focus segment on communication and quality improvement.
Let's start by putting everything in perspective. That is referring back to the Medicare conditions for coverage. So 41643, condition for coverage, quality assessment, and performance improvement. The ASC must develop, implement, and maintain an ongoing data-driven quality assessment and performance improvement, or QAPI program, and the interpretive guidelines. The QAPI conditions for coverage requires an ASC to take a proactive, comprehensive, and ongoing approach to improving the quality and safety of the surgical services it delivers. The conditions for coverage presumes that the ASC employ a systems approach to evaluating their systems and processes, identifying problems that have occurred or that potentially might result from the ASC's practices, and getting to root causes of problems rather than just superficially addressing one problem at a time. From a survey perspective, the focus of the QAPI condition is not on whether an ASC has any deficient practices, but rather on whether it has an effective, ongoing system in place for identifying problematic events, policies, or practices, and taking actions to remedy them, and then following up on these remedial actions to determine if they were effective in improving performance and quality. QAPI programs work best in an environment that fixes problems rather than assigning blame.
So in that last sentence there, QAPI programs work best in an environment that fixes problems rather than assigning blame, really gets to the heart of our theme, which is developing a culture of quality. And in particular, we want to talk today a little bit about communication in that environment. So let's start by talking about the importance of identifying opportunities for improvement. So there are many mechanisms, as we know, for identifying opportunities for improvement, and a robust QAPI program will have a wide variety of such mechanisms. So let's just mention the most common mechanisms in the ambulatory surgery environment. So things like the review of transfers to the hospital, unexpected transfers to the hospital. Well, any transfer to the hospital should be unexpected. You shouldn't have any planned transfers. Chart audits, which would include like nursing chart audits as well as peer review chart audits of the providers. Satisfaction surveys, those are the things that you send out on a regular basis to your patients to find out, what their experience was like and to also solicit feedback. The infection control oversight and surveillance, performance of environmental rounds, cancellation monitoring, tracking and trending of QAPI findings, which are also known as internal benchmarking, external benchmarking of QAPI findings, and of course, arguably the most important, which is incident reporting. So incident reporting, Sue, as we both know, is one of the more controversial areas and often one of those areas that it's very difficult to get an ambulatory surgery and in particular the physicians to buy into. I remember in one of our centers having an argument with a doctor who he actually said to me, if I ever find somebody doing an incident report, I'm going to fire them. And his reason for that is that he felt that he ran such a great place that all of those issues should be resolved before they turn into an incident. And I used an example. I said, doctor, I know that this last week you had a problem with regard to cleanliness and that you found some dust bunnies in the corner in your surgery center and you immediately called up the cleaning company and you kind of read them the riot act about their poor cleaning in that particular area. And as a result of that, changes were going to occur. The cleaning company was going to take a much more robust approach toward cleaning. And I said, that's an example of an incident. The incident was poor cleanliness. You followed up on it. In other words, you closed the loop by communicating with the cleaning company. You asked them to change, and then you will continue to monitor and make sure those changes were made. And all that we're asking for in the QAPI environment is to take those types of situations and write them up as a quality improvement incident. So this isn't something that immediately affected patient care. It didn't reflect poorly on anybody in the surgery center. And it kind of shows that your organization takes very seriously all the things that happen in the organization. It has monitoring in place in order to identify those problems. And, the interesting thing is after that, he fully understood. He really became, quite an advocate for incident reporting because he understood the need for this. Now, I should point out that I'm not going out and recommending that everybody write up an incident report anytime that they find a cleaning problem. But in this particular environment, in this particular facility, there really weren't a lot of things that went wrong, thankfully, and knock on wood, of course. And what we want to do is I try to encourage people to try to find, 4 to 5 at least incidents within a quarter to demonstrate the types of things that are going on in the organization. And the important point to be made here is that robust incident reporting helps to prove that you have an active and robust quality improvement process in your organization. So as surveyors, when I go into an organization, I want to see incident reporting because this helps to show me that they are really taking it seriously.
It shows that the quality in your organization isn't just accidental. So like you always say, John, if there's not a large incident, you keep kind of backing it up. And at some point, you're preventing those larger incidents by catching the smaller things. And so that's what you write up. You just show how you're getting in the way of letting things get worse.
Another way to look at it, too, is that if the only incidents you ever have are the really serious ones, that makes it sound like you're hiding all the others or that you're not taking this process seriously. So when you have ongoing incidents and then something does happen, like an adverse event, it really kind of points out, first of all, that you're taking it seriously, and second, that the only events that happen there are not the serious ones. And again, the surveyor can see evidence of an ongoing, remember that word, that phrase, ongoing program in the ASC environment. So good incident reporting requires really good communication in your organization and understanding the role of incident reporting in your quality improvement process. So what you really need to do here is to encourage reporting. One of the things that I always did with new centers starting up is I would tell them that I wanted to see 3 incident reports generated for that first day of operation, which was usually not a big problem because all kinds of things go wrong, obviously, on that first day. And then just to get them into the habit of doing incident reporting and recognizing that it's not just for adverse events. So a good incident reporting system will encourage people to report things that fall outside normal parameters. So the obvious ones are, of course, transfers to the hospital, surgical complications, anesthesia complications, other clinical incidents. Not so obvious ones might be equipment breakdowns, particularly equipment breakdowns that happen during surgery that might require some type of intervention or delay in surgery.
And I think that was a little bit of a learning for me when I started hearing you talk about this, is that even if something breaks down and there's no patient harm at all, and it really doesn't, even if it doesn't really even delay anything, you still have to, write that up. And
or encourage you to write it up.
Yeah, it's not a requirement, but that it's important to keep track of that. that can be an incident.
Right. Another way to look at it is, this is how I approach it with nurses, because nurses, as you know, Sue, you just fix things. Mm-hmm. That's your job. Something goes wrong, you fix it. You don't take credit for it. You don't care about taking credit for it. But incident reporting provides you a mechanism for demonstrating the work that is going on a daily basis on the nursing side. And again, we could take this to extreme. I can remember back in the days when I was an administrator, I encouraged incident reporting way too much, and I used to get 40 to 50 incidents a month, which would take up almost all my time. And, at a certain point, I just had to kind of say, listen, these are not incidents here. I appreciate the fact that you're bringing them to my attention, but let's kind of focus on a certain level. So you're moving that bar around to get to an appropriate level. Obviously, if you have a lot of adverse events, those things absolutely have to be reported. But it's those things like equipment breakdowns or communication breakdowns or cleaning issues that you don't necessarily need to do unless they're, quite major.
But sometimes, too, if it's in a larger center, just keeping track of those things can help you identify if there's a trend, because if there's a lot of different staff and this one machine keeps breaking down, everybody may think it's the only time it's happened.
Right.
So, the more you can track it.
Right. And to that point, of course, you're getting ahead right now.
Sorry.
No. But to that point, this is a way of keeping track of those ongoing problems that occur. Like if you see that your sterilizer is down every single month, you'll start to see those incidents, and you should be tracking and trending all of these incidents, of course. You can see that trend and start to say, well, wait a minute, maybe it's time to consider, replacing this piece of equipment. And ultimately, this all gets down to what we discussed earlier, developing a culture of quality, which really starts with your educational program. And I really feel that it's important, both at orientation, but especially on the annual mandatory education, that you spend an appropriate amount of time, perhaps 15 minutes every year and upon orientation, discussing with your staff how to do appropriate incident reporting and how you're going to communicate the results of that incident reporting back to them afterwards. So you need to make sure that you develop a team approach to identifying, researching, fixing, and communicating changes in your organizations. In September, we spoke to Ann Shimek at the California Association meeting where she presented a session on developing a culture of quality in an ASC setting, which really kind of takes what we've just been discussing in a little more depth and particularly talking about the culture of quality. So let's listen to that interview.
John and I are now talking with Ann Shimek. She has been in healthcare for 30 years. She was formerly with a large ASC management company and currently an independent consultant with Ann Shimek Clinical Pathways, LLC. Welcome.
So welcome to the podcast. It's great to have you on.
Thanks, John. It's nice to be here.
And tomorrow we're recording from the annual CASA conference out in Monterey Bay here. Beautiful location. And tomorrow I'm moderating a session that you're going to be on. So, Ann, you just finished a session on developing a culture of safety in ambulatory surgery centers. I thought that would be a great topic to talk about here on the podcast. So tell me a little bit about the presentation.
Okay, so the presentation covered topics of things that they can do at their individual ASC facility to enhance the culture of safety for the patients, to ensure that we're providing the highest quality of care. In order to create a strong culture of safety, you need to have employee engagement, and it also impacts the quality of care that you deliver. Without one of those components, you are not going to be successful in any one of those areas.
So, you came from a large management company, and large management companies have, lots of resources. How can a small center, like our average listener here, how can they develop that culture?
So that was one of the things that I wanted to really provide during the presentation, were things that they could take back and use at their facility, things that are easily to implement, ideas, suggestions. One of the first things that comes to mind is doing a daily huddle.
Yeah.
When I first talked about this at an individual ASC level, they're like, oh, that will never work. We're way too busy. Yeah. We don't have time.
Doctors won't allow us to do it.
Overstretched. all of those things that are all excuses.
Right.
Because really, when you're talking about delivering high quality health care, it's all about communication. Mm-hmm. In the United States, there's nearly 440,000 deaths a year related to medical errors that should never happen.
Absolutely.
It's now become the third largest reason for death in the United States, only behind cancer and heart disease. So it really is an area where, especially in the ASC, when things change, when patients come in and change their minds. We're scheduled to do a procedure on my left knee, and today my right knee's hurting, so we're going to change that. How does that get communicated to the scrub tech that has printed off the schedule from yesterday? So those are why all of these things are so important. So a daily huddle is a perfect example of setting aside 10 minutes a day, a certain time of day, whatever works best at your center, whether it be in the morning or early afternoon. And one person from each department comes to the meeting. We don't bring chairs because we're not going to be there that long.
Yeah.
We include the materials manager. We include somebody from the business office and pre-admission test person. Everybody comes. They talk about today. How did today's schedule go? What issues did we have, if any? What went well? What should we do more of and what should we do less of? And then we talk about tomorrow's schedule. We make sure we have all of the implants that we need for the schedule. We make sure we have the cases all pulled correctly. It's at that point in time where the pre-admission nurse can talk about the patients that are coming in. Is there a patient that has multiple comorbidities that we should probably have a physician review prior to the day of surgery? Do we have enough staffing on board to cover the schedule at the right times? All of those kinds of things. Are there any patients that have similar names that we should be concerned about? It takes about 10 minutes. The participants at the facility are responsible for going back and communicating what was talked about in their departments. And it really just, once you get it down, like I said, it can run very smoothly in 10 minutes time and really share a lot of information that everyone needs to know and hear about.
So how's that going to improve and develop a culture of quality?
So it develops a culture of quality because things don't slip through the cracks.
Yeah.
We're able to identify potential problems. We're able to discuss when an incident occurred, where was the breakdown. It's important when things break down that we focus on the processes rather than blaming people.
Correct.
Because obviously one of the key things in creating a culture of safety is making sure that everyone has a voice and everyone feels like they can speak up and express a concern on anything that could be out of the norm. Oftentimes it's not so, but they have that chance to be able to speak up. I think one of the things that really is key when you're creating a culture is getting physician engagement.
Yeah.
You need to have a strong medical director that is concerned about quality, always comes first. They're willing and able to step up and have crucial conversations with other physicians so that you don't lose that culture, that somebody feels intimidated. We talk about airline industries a lot and how they have checklists and the checklists work. But what we don't talk about is the level of education. Both of those pilots went through the same level of training and the same number of years of experience. In the OR, it's much different. You might have a scrub tech that has graduated from high school, is a single mom with 2 or 3 kids she's responsible for. And is she going to feel comfortable to speak up when a doctor says, I'm the captain of the ship and what I say is always right. Don't ever question me. And although we've made a tremendous progress in having a teamwork approach, we still have that amount of uncertainty in people that they're going to be protected. Crucial to having a strong culture of safety is having a firm stop the line policy in place that everyone knows about. So when you raise up this question, I am concerned that this is the wrong dose of medications and we don't get a response. Now I'm uncomfortable that this is the wrong dose of medication. And then it's a stop the line where the employee goes and calls their manager. Manager drops everything, goes back and assesses the situation. And most importantly, thanks the employee for being willing to speak up. Very, very important that everyone feels they're empowered to be able to speak up at any time.
Yeah, whether the concern turned out to be anything or not.
Absolutely.
Just always
and it
need
can
that
never be
backup or it'll
discounted
never.
because if you discount it, then that employee's not going to speak up next week when the same situation.
And in that case, they might be saving the surgeon. So
Absolutely.
it's nice if they appreciate.
Well, I think it also brings up another issue that the first time an administrator or nurse manager does not stand up for that employee, that's the last time that employee will ever even think about
and you're sending a message to every other staff member that really we don't support you. It's more about getting things done and the bottom line, or getting more cases, doing more with less. And that's where it's a very, very fine line. Mm-hmm. We're very efficient in the ASC world. The physicians love to come to us. Our patients love to come to us, but it's also where you can't cut corners, because when you start cutting corners, you lower the bar of expectations, and that's when bad things happen.
So one of the things that we always look at when we're recruiting nurse managers is having that ability to stand up for the doctors. Talk a little bit about that.
Yeah, so standing up to the doctors, it can be a challenge, definitely. Things that I have found to be very helpful is to have an administrator, have a clinical director that are able to sit down and be reasonable with the physician, take them data points. Physicians love data, and when you can show them how something is affecting the culture, then that's how they're going to listen. So I think the best thing to do is to have this conversation, not at the beginning of a 15-case day where we're going to have bitter and be angry all day, but sit down with them, whether you go to their office, take them some cookies, whether you invite them for a cup of coffee or lunch, and really just explain to them how their behavior is impacting the staff, that the staff are intimidated or the staff feel rushed and that they're concerned. Oftentimes when you have those conversations, they don't realize it when they're in the mode. I always say that when a surgeon comes in to do a lineup of cases, they're in the zone, and they get in that zone thinking about the next patient or the patient that they just completed, and they don't realize how their actions are impacting other people. So if you can have that conversation with them, that usually helps. Sometimes it's important to get another physician to have that conversation so that it's a peer-to-peer conversation rather than coming from a nurse to a physician. So there's ways that you can handle it, and most of the time, they're pretty reasonable, and they want to make sure that the right thing is done for their patients. So, but it's just about bringing it to their attention a lot of times.
Well, and you bring up a very good point, because I think most of the time when we talk about correcting problems, we want to correct it at the time that it's occurring. But that's not always a good idea when we're dealing with the population that we're talking about here with physicians who are dealing with very complex procedures.
Exactly. And the last thing you want to do is send them over the edge at 7 o'clock in the morning, because it's just going to snowball. It's not fair to the patients. It's not fair to the staff. And it's honestly not fair to the physician. So, timing is everything with these. I usually encourage administrators to always have a bowl of chocolate in their office so that they can, the physician stop by. I think it's also important to talk to the physicians on a routine basis about how are we doing? What is there anything that we could do to provide a better service to you? Because oftentimes they get frustrated. I call them pet peeves, but they come in and their patient's not ready. Sometimes it's in our control. Sometimes it's not. But, they can't find the right scrubs. They can't, all of those things can become a frustration. I've asked 4 times to have this suture available for this case, and it wasn't ready today. So if you can identify some of those things and, work with them, they're really pretty reasonable and will definitely work with you.
Yeah, and I think the point you're making is they're often not the big items.
Right, exactly. It's the little things. I remember going into an ASC to get started for the day, and I'd go to set up IVs, and there was no IV tubing, so you had to go find it. Any of those things that you can do to kind of alleviate those frustrations from a nursing perspective to a physician perspective to a patient perspective, it's always going to make you more successful. And again, really work to build up the team.
So you talk a little bit about the feedback loop, and how do we reward people for doing the right thing, for bringing these things to the attention of management, and then continuing to encourage them to be part of the process. And again, recognizing that some of these people barely have a high school education when they come to work for us.
So it's really important to reward and recognize. Exactly. And there's easy ways that you can do this that aren't expensive. Wall of Fame in the lounge, where you post patient comments where they really, react to how a nurse treated them goes a long way. We're all very competitive. If we see Becky's name on the board in the lounge, we want to make sure my name is up there.
Yeah.
Another good way to recognize employees is to allow the employees to recognize each other. Mm-hmm. So, if Mary puts a note up that John did a fantastic job with a really difficult patient today, that's going to make everybody feel better. So include the physicians in that too. Mm-hmm. So that's an easy way. Other ways, you always talk about the OR, and food is always near and dear to everyone's heart.
That's why I've been on a diet for the last year. Yeah. 17 years of eating that food.
Yeah. And that's why we all, 11 o'clock in the morning still. But I think that sometimes becomes routine. Yeah. So, and I also think you just need to remind them when you are doing things for them so that they remember, she is going above and beyond what she really needs to do. And easily just thanking them. Yeah. Thanking them for a nice job, or walking through the lounge, and if one of them is eating lunch, say, you really did a fantastic job with that patient today. Yeah. We really appreciate your expertise.
Instead of, why are you taking 15 minutes for lunch?
Right, exactly, yeah. Complaining about the dishes not being done, right?
And it's not always about the money.
No, it's not.
Yeah.
Another really effective way is to write them a thank you note.
Yeah.
Write a thank you note, mail it to their house. They can share it then with their family. Their family recognizes what a good job they do. And that's something that you can easily do that doesn't cost anything. It's a little time, but it really does make a big impact.
I've always found it interesting over the years that, we've always done that, where we encourage, when we take the post-op surveys and we publish the names or put the names up on a board so everybody can see. But you have to be careful with that, because the people that they remember are almost always going to be the PACU nurses.
Exactly.
And if you don't somehow find a way to bring the nurses that the poor patient doesn't remember because they forgot forgot their names.
One way we've gotten around that has been really impactful is we put a thank you note card on the front of the chart, and everybody who interacts with that patient signs it. It's thanking them for entrusting us to take care of their health and to take care of their surgery. It also brings that to light, that OR nurse was really friendly. Yeah, her name was Carol.
That's a great idea.
They can, then recognize more than just the PACU nurse who brought them that nice hot cup of coffee.
Right. Well, I just finishing up, we spend most of our time in quality improvement, and a lot of what we talk about in the podcast here on a regular basis is quality improvement. So the quality improvement process, the quality improvement meeting shouldn't only be about the people that have licenses.
Right. It shouldn't be about just them. It shouldn't just be about hand hygiene.
Right.
It should be about, the team and how they're doing in these areas. Again, part of that meeting should be recognizing how many good catches we've had. Good catches are when something potentially could go wrong, but we catch it before it reaches the patient.
Right.
And those are really important to talk about, because those help us identify where we have potential breakdowns in processes that we can go back and correct prior to it reaching the patient. And again, those are the employees too that we should be recognizing and rewarding as well.
Right. Thank you so much. I really appreciate your time.
You're welcome. It's nice to be here.
Thanks. So, Sue, as we were preparing for this section, we just got news that our puppy has been born.
Yes.
So we're very excited. There were 3 girls and 2 boys, and we have, I think, pick number 2, if I remember right, on the girls' side. So we're very excited. Hopefully we'll get pictures shortly, and we'll try to post them so that everybody can share in our excitement. So we have no state issues. Again, I would encourage everyone to, as Michigan did for us, to pass on information on state-specific issues. Sue, also, we announced on LinkedIn that I have been working with Diana Powell to develop a state-specific series of books for ambulatory surgery centers. So it's gotten quite a bit of feedback. Our first book, which is for the state of Massachusetts, is already out. Pennsylvania has been out for a while. We had an individual who suggested that we publish one for Arizona in celebration of the fact that this is the 50th anniversary and the first surgery center was developed in Arizona and also Georgia. So we will be working on those. Certainly it's going to take us a while to get them all done, but we're continuing to work on it. But if you do have any state-specific issues, please bring them to our attention by emailing us at info@ascpodcast.com.
You're never alone in the ASC industry. Many organizations are eager to provide an opportunity to keep up on all aspects of running an ASC, and in this section, we highlight upcoming events.
If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
As one of the most sought-after speakers in the industry, John is available to speak at your state or national meeting, and the ASC Podcast with John Goehle can even record an episode from your meeting.
The first ASC Nurse Leadership Conference presented by Progressive Surgical Solutions will be Thursday, February 6th and Friday, February 7th at the McKesson headquarters in Dallas, Texas. As we talked about earlier, Ambulatory Healthcare Strategies is a proud sponsor of the event, and we hope to record a special episode from there.
The Georgia Society of Ambulatory Surgery Centers and South Carolina Ambulatory Surgery Center Association's joint semi-annual conference and trade show is February 20th and 21st at the Westin Atlanta Perimeter North in Atlanta, Georgia. The
HHC Achieving Accreditation is an interactive, in-depth 2-day seminar designed to help organizations prepare for the HHC survey. And the next one is March 13th and 14th in Miami, Florida. If you're considering a change from IMQ to HHC, this is a great opportunity to learn more about HHC.
This year's National Advocacy Day is taking place in Washington, D.C. on March 24th and 25th. Participation in ASCA's National Advocacy Day is the best way to build relationships with your members of Congress, advocate for your ASC and the ASC community, and network with other ASC leaders.
The AORN Global Surgical Conference is in Anaheim, California, March 28th through April 1st. We'll be attending the conference and recording a special episode there with interviews of speakers.
The Florida Society of ASC's Quality and Risk Management Conference is April 16th and 17th in Buena Vista, Florida.
The Iowa Association of ASC's 12th Annual Education Conference is April 17th and 18th in Johnston, Iowa.
ASCA 2020 is in Orlando, Florida, May 13th through the 16th. It is the ASC industry's most highly regarded and well-attended event. Attendees include physicians, administrators, nurses, managers, and owners of ASCs from across the country and throughout the world. At ASCA's annual conference, you will find more than 50 educational sessions designed for ASC professionals at every level, nationally recognized ASC management experts, networking opportunities with more than 1,000 of your colleagues, hundreds of exhibitors who can help you find the solutions your ASC is looking for, the latest regulatory and accreditation updates. Make sure you sign up to attend, and of course, a lot of the company will be there.
Right. Looks like somebody's going to be taking care of the puppy.
I always end up reading this one, and I don't want to say we will be there because I won't be. But
Becker's 18th Annual Future of Spine, the Spine Orthopedic and Pain Management-Driven ASC Conference is June 18th to the 20th, 2020 in the Swiss Hotel, Chicago, and, of course, Chicago, Illinois.
The Florida Society of ASC's annual conference and trade show is July 15th through the 17th at Walt Disney World in Orlando, Florida.
And the Ohio State Association Conference will be September 30th through October 1st at the Hilton Columbus Polaris in Columbus, Ohio.
Well, that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button.
The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all the rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development, all rights reserved. We would like to thank this week's sponsors. First, Ambulatory Healthcare Strategies, one of the nation's leading regulatory compliance and financial oversight firms. For a free consultation, contact John Goehle today at 585-594-1167 or through email at info@ah-strategies.com. And Eden Group Development, which publishes ASC Regulatory Compliance Series, the ASC industry's leading books including the Survey Guide for ASCs, a guide to the CMS Conditions for Coverage and Interpretive Guidelines for Ambulatory Surgery Centers, and Ambulatory Surgery Center Governance, a guide for ambulatory surgery center owners and governing body members. These must-have books are available on Amazon and Barnes & Noble or directly from the publisher at reg-books.com. That's reg-books.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.